Good morning, everyone. Thank you for joining us this morning. My name is Camilo González Velázquez. I'm an associate professor in endocrinology in the Universidad Autónoma de Nuevo León in Monterrey, Mexico, and co-host of this TIRO by MD's webinar series. Today, I'm honored to introduce two very well-known and wonderful speakers who we want to thank for their time and willingness to share this morning with us. Dr. Givi is an associate professor in otolaryngology, head and neck surgery, and NYU Langone Health and chief of otolaryngology in Manhattan VA Medical Center. He received his medical degree in the University of Tehran and followed by his surgical training in Oregon Health and Science University. He completed fellowship training in head and neck surgery at Memorial Sloan Kettering Center in New York and the University of Toronto in Toronto, Ontario. His main areas of research are head and neck surgery education and outcomes in head and neck thyroid malignancies. He serves as the vice chair of the education of the American Head and Neck Society and associate editor of the Journal of Otolaryngology, Head and Neck Surgery of the American Academy of Otolaryngology. As well, today we have Dr. Yuri Nikiforov. He's a professor in pathology and vice chair of the molecular pathology at the University of Pittsburgh. He's published over 200 peer-reviewed articles and over 20 book chapters. He's senior editor of the textbook Diagnostic Pathology and Molecular Genetics in Thyroid, which is now in its third edition. His research program has been funded by the NIH continuously for over 20 years and is focused on molecular mechanisms in thyroid cancer, radiation carcinogenesis, and molecular diagnosis. In 2016, Dr. Nikiforov led an international group of physicians and scientists to reclassify a type of thyroid cancer known as a non-cancer, which is, we all know and widely recognized, NIFTP, which allowed to eliminate cancer diagnosis for thousands of patients worldwide. He's an elected member of the American Society for Clinical Investigation and recipient of the 2007 Van Meter Award and the 2017 Sidney H. Ingwer Distinguished Lectureship Award from the American Thyroid Association, and the 2016 Aldo Pinchera Award in the Italian Thyroid Carcinoma Observatory. Before we continue, we would like to write your questions through the Q&A function, and we will try to get to as many of them by the end of the hour. Today I'm really happy. This is our 99th session since we started this endeavor at the beginning of the pandemic. And without any further ado, Dr. Givi, the mic's all yours.
Thank you. Thank you for having me. All right, can you guys all see my screen?
Perfectly.
Okay, perfect. Well, good morning. Thanks for having me. It's a real pleasure and a privilege to be with you this morning and present my work on genomic classifiers and thyroid nodules, what I call what good is a newborn baby. Obviously, I cannot say anything about science when Yuri is here, and that's not my intention today at all. However, what I'm going to talk about is how people like me as clinicians will interact with this new tool. I have nothing to disclose. So for this audience, there's not much to say that thyroid nodules are very common. The incidence increases with age. Up to 1/3 of population will have them at some point. We do more ultrasound, we do more imaging, we find more of them. And as you know, there are about 20–30% of these come back as indeterminate. I am a huge fan of the Bethesda system. I think that was a revolution in classification and kind of figuring out what we are talking about. But with all the help that we are getting from the Bethesda systems, people like me, clinicians, we still have these Bethesda 3, Bethesda 4 that says atypia of undetermined significance. And I would argue that what do you think the patients will think when we tell them, well, you have a nodule and we don't know the significance of it? Don't you think they're going to say, well, doctor, why don't you figure it out? And we have to say, well, the only way to figure it out is we have to go and take half of your thyroid out, or your thyroid out to figure out. And if you are sitting in that chair, how do you like that? That the only way that we can figure out the significance of this nodule is to do an operation, go inside your neck, go around your thyroid, dissect your recurrent laryngeal nerve, push your parathyroid away, take this out, and then we're going to say, well, good news, it was nothing. And I think our patients have a point, and we should, the burden is on us to change and try to do better just to do surgery. And what can we do to determine the undetermined? And as you all know, now we have different tests. We have Afirma, we have Thyroseq, we have Thyrogen. I'm sure there are more. These are the three that I have seen, and I have looked at the results. No. And there are a lot of publications. This is Thyroseq. And you can see I like this because it gives you a very nuanced algorithm. It starts from negative, and then there are different levels of positive, which I like, actually. It's not as simple. It does include the nuance of diagnostic. But I would ask you that how do we interact with these? How do we interpret these results? And after this came out, other institutions looked at it, and they said, the performance is variable depending on where you are, and they figured that the PPV might be a little bit lower. This is the work of Luke Morris and Alan Ho that they showed in different places. It's a little bit lower than what we thought, especially when we changed to NIFTP, which we just mentioned. And I would say NIFTP, the reclassification of NIFTP is one of the greatest goods that we have done. And if Dr. Nikiforov doesn't do anything for the rest of his life, the fact that he has saved thousands of patients from the label of cancer will grant him a place in the highest levels of heaven. Imagine how many thousands of patients now, they are not to be worried about having the label of cancer. And that is one of the greatest achievements, I believe, in thyroid pathology. So, question for us is, how is this new tool being used? Now that we have all these things, and now we have all these questions, how are we using it? And my question specifically for this work was, what happens when we test all Bethesda 3, Bethesda 4 nodules with Thyroseq? And how do clinicians interact with and interpret these results? Remember, the test doesn't operate on people. We operate on people. The test gives us results. How do we interpret these results? And let me give you a couple of examples. Patient of mine comes in, 2-centimeter nodule, looks like a very adenomatous nodule. We biopsy it, it's Bethesda 3, we send it for Thyroseq, it's negative. I say we should watch it. The patient is like super nervous. I wanted that, I wanted that, I wanted that. How do you guys know? On the other hand, here's another one. It's about 4.5 centimeter, and you do the Thyroseq and it's positive. And now I am the surgeon, I'm worried that, well, it's positive, so maybe not only I need to do a lobectomy, maybe I should do a thyroidectomy, total thyroidectomy, because if it's positive, then it might be bad, then you might need a completion, then you might need an REI. So how do we interpret these results? What happens when we have all these things? So to answer these questions, and especially, a lot of time in tumor boards, this comes up that says, well, you're doing a teeny tiny FNA, you're just getting like 5 cells. How do you know a centimeter over there is not a difference? How do you know that this is the actual true pathology of this nodule, especially when you're talking about a 4.5 centimeter large nodule, Thyroseq negative? Do we believe that? Really, you believe that? And then, us surgeons, we love to talk about anecdotes, and we all bring up, I had a patient that we didn't do this and he had bad cancer, or she had bad cancer. It's not coming from a bad place. It's just the burden of responsibility for us. We are all nervous. And those of you who play poker, you always remember the bad beats, not the successes. So sometimes even when we see these evidence, we are still being very nervous about it. And my goal was to see, are there any reason for our nervousness, or should we trust you? So what did we do? We basically looked at everybody who had a diagnosis of Bethesda 3, Bethesda 4 from 2014 to 2018. And we only selected patients who had Thyroseq testing and had surgery. So we wanted to have a complete data set. And then we also matched all the FNA biopsy nodule with the final surgical pathology. So if the patient had an incidental micropapillaries, other stuff, that didn't count. What did we find? We find about 826 Bethesda 3, Bethesda 4 nodules with a Thyroseq testing. Right off the bat, we observed about 680, which 396 were negative. So you can see by doing that, we already saved a lot of people from having surgery. The rest, about 212 patients for 218 nodule underwent surgery. And this is our data set. This is the patient that we found. What did we find? We find about the age is about the same, about 50-year-old, majority are women, as you know. Even in New York City, we still have majority of them are white. The nodules are not small. These are about 2.5 centimeters, give or take. Majority were Bethesda 3, and a lot of them were Thyroseq positive, 80%, because we don't operate as often on Thyroseq negative nowadays. But then when we looked at the interpretation of the pathology, only about 24% of them were labeled as malignant in the final pathology, which was very interesting to me, because we thought that we should have more. If you have like 79% of them are Thyroseq positive, why there's only 25% are malignant? So we looked at the pathology. These are the benign nodules. As you can see, there are about 40% of adenomas, a significant, almost equal number, 37% were NIFTP. So right there, we do know that the NIFTP nodules will look positive on Thyroseq, and that's totally fine. The rest were hepatocellular adenomas or nodular hyperplasias, and there were other results. Well, I'm more interested in the malignant one. What was the malignant one? If you look at it, the majority of follicular variants, then it was classical PTC. There were a few tall cell, and there were like 2 or 3 partial cell. We didn't identify any poorly differentiated, or we didn't identify any other bad, locally aggressive, invasive nodules. And I would argue that this is very reassuring, because it tells you that if you have a Bethesda 3, Bethesda 4, and you have Thyroseq, the chance of missing or the chance of having a poorly differentiated, high-risk malignancy is extremely low. Then we looked at our overall performance, do the normal statistics that we do. We found out that our NPV is very good, it's 87%, and our positive performance, PPV was low, 27. However, once you add NIFTP, then it gets much better, it got 61%. Nothing earth-shattering. This has been described in many other studies, very similar to what you find in other places. Very good, very high negative predictive value, which I would argue as a surgeon, that's what I really care. That I do not want to miss a passage. But then we went back to the original question. Can we trust these results when you have a large nodule? What will happen if you have a big nodule? So we then divided based on size and looked at the nodules were less than 2 centimeters. You can see the negative predictive value is pretty good. It's about 80%. Positive predictive value is low. So again, we are not missing too many bad malignant tumors. When the nodule gets bigger, interestingly enough, not only the negative predictive value doesn't decrease, it stays the same. So the test is adequately performing what it's supposed to do. It rules out malignancies. Again, our negative predictive value is 90%. Now we're talking about nodules of 2 to 4 centimeters. So these are not tiny nodules. And then let's take one step further. What will happen is you have really big nodules, more than 4 centimeters. Now you're talking about nodules that if you are worried about cancer, you have to do total thyroidectomy. Interestingly enough, the positive predictive value went up, which makes sense because there are more cancers in this category. But again, negative predictive value did not go down. It stayed at about 90%. So let's ponder on this for a second. The larger the nodule gets, Thyroseq actually gets better, which is very counterintuitive with what we thought about, FNA and others. Instead of us being worrying about, oh my God, I'm gonna miss, maybe I biopsy the top, not the bottom, not the middle, not the side, and I'm gonna miss a big one and need to take this out. No, we did not find any evidence that this is a bad thing. And actually, the specificity went up as the nodule got bigger, which is completely counterintuitive with what we thought about when we started this research project. Because really my interest was to see what should we do with big nodule. 1 centimeter, 2 centimeter nodules, how many times people have died on a 1 centimeter, 2 centimeter nodule? But then you're talking about nodules larger than 4 centimeters, which to this date, if you look at the ATA, talks about total thyroidectomy upfront. Those are the ones you're interested in, how to manage those. And looking at this data, you can trust the results of your pathology, FNA, and your Thyroseq, that you're not going to miss a big bad cancer, which is great. But again, as I said, what do these findings mean? What do these findings mean to me as a clinician? If I'm going to summarize it, I would say we can believe Thyroseq results even in a big nodule. The risk of missing a higher risk malignancy is very low when you have the combination of a Bethesda 3, Bethesda 4 by is trained cytopathologist and Thyroseq, and almost everybody can be treated with lobectomy up front. Now, I haven't told you about this last point, have I? Why do I say this? Why I say almost everybody can be treated with lobectomy up front? Because we looked at the rate of our completion thyroidectomy in 142 patients who started with a lobectomy. In patients who were Thyroseq positive, only 7 out of 121 needed completion, 6%. And when they were Thyroseq negative, only 1 per patient needed completion. So if you adopt a paradigm of, if I see a Bethesda 3, Bethesda 4, and my Thyroseq is not showing medullary thyroid carcinoma, or the stuff that we all know how to treat, it's, if you do a lobectomy upfront, 94 to 95% of the time, you are correct, and you don't need to have a second operation. And if it's me that have that disease, I'll take these odds. There's a 5%, 6% chance, at least in our institution, that I would need a total thyroidectomy. And I would rather have half of my thyroid. What about radioactive iodine treatment? What about how many of these folks will need radioactive? Again, when we looked at it, when they were Thyroseq positive or negative, only about 17 patients at the end needed to have radioactive iodine. So these are the patients that either had total thyroidectomy up front or had a completion, and then eventually were recommended to have total radioactive iodine. Very, very low chance that you need radioactive iodine. So if you don't need radioactive iodine, you don't need a completion thyroidectomy in most of the places. So again, I would argue that for majority of these cases, regardless of the size, we can safely recommend lobectomy. We have the information. And actually, after we published our paper in JAMA Otolaryngology, we got a letter from the editor from the Alan Ho and the group in Sinai, because in our paper, we were very cautious, and we said, if it's more than 4 centimeter and the Thyroseq negative, lobectomy is adequate. And they argued and said, well, based on your data, even if it's Thyroseq positive, we still can do lobectomy, and they're correct. The reason is we didn't have that many patients. The number of patients here is low, so we are just trying to have some humility based on a few patients. So let's go back to this. Now, what does this mean? That now we have all these nuances that, yes, these are Thyroseq positive, but as you can see, these are not all created equal. And I really like this because, and I commend Yuri for bringing this nuance to management of thyroid nodules. Not every positive is equal. So you have positive that are high risk mutation and you have positive that are low risk mutation. And this is important for us clinicians to know and important to interact with adequately. Because as I said, at the end of the day, I am the one who is operating on the patient. And it's on me to determine what these findings mean. And the more we pay attention to that nuance, I think the better we are off and the better our patients. And you might think that, oh my God, this is too much, just keep it simple. But I would argue that this is how reality is. This is how nature works. There are a lot of details. There are a lot of nuances. And we didn't know these because we didn't have this test. But now we do. And now we're looking inside the cell. We're not just looking at the H&E slide. We're also looking at the genetics. And I'm going to finish by a few points that I learned. I highly recommend, if you have a few minutes, to read this essay by John Salvatierra, that reality has a surprising amount of detail. It was published in 2017. He is a philosopher and AI specialist. It's one of the most beautiful essays that I have ever read. And in part of it, it mentions that you might also hope that the important details will be obvious when you run into them, meaning that if you see a detail, if you see a cancer, you identify it. But such details are not automatically visible even when you are directly running up against them. Things can just seem messy and noisy. And that is very true. We think that, oh, if we find a nodule, if you look at it under a microscope, oh, it's cancer. No, it's more complicated. We go one step forward. If you look at the genetics, we're going to find it. No, it's even more complicated. And he argues that the direction for improvement is clear. Seek detail you would not normally notice about the world. And what does it mean to seek detail? Seeking detail means to do these things, to look at malignant nodules, not just by H&E, but also look inside them. Do these tests like Thyroseq. This is our profile of all the nodules that had cancers and had their genetic mutations. It's a very noisy picture. What does it mean? It means that there are still details that we don't know. We are in the beginning of the dawn of a new age. And that, to me, as a physician, as someone who interested in science, is very reassuring. It's beautiful. It's amazing. I am comfortable with not knowing. I like the nuance because the nuance and newer stuff will always end up in better things. And I'm just going to finish by a couple of examples. So the title of my talk was, What Good is a Newborn Baby? I don't know if you don't know this story, but Benjamin Franklin was the ambassador to the French court. He was very influential in having the French finance American Revolution, and actually the peace treaty between US and Britain was signed in Paris. While he was there, he was a celebrity. There was this very famous picture of him with this fair hat, which he never wore when he was in Philadelphia, but over there, he was trying to give this impression of the frontierman to all the French folks. During his time, Benjamin Franklin was also a scientist. On August 27, 1783, the first hot air balloon by the Montgolfier brothers went up in Paris. And Franklin was very excited about that. He wrote to the Royal Society in London. He was very, very excited about this new development. And obviously, when you're in the crowd, he was in the crowd watching this, somebody brought the proverbial question, what good is it? What is this thing? It was just a gigantic thing with a hot air and smoke and everything going up. What does it do? How is that going to change my life? And Franklin, being a witty guy, immediately said, what good is a newborn baby? When a baby is born, it can't do anything. It's just sitting there, you have to feed her. it just poops all the time and cries. But things will change and things will get better. So I would ask you, what good is Thyroseq? And I would argue that we don't even know what good is Thyroseq. And tests like these. Look at what we have found out with just looking at the genetics of thyroid cancers. This is a famous paper now by the folks in MD Anderson that complete surgical resection following neoadjuvant treatment with BRAF positive anaplastic thyroid carcinoma. You have seen all these results that we can start neoadjuvant treatment and suddenly these massive tumors will go away. What does that mean to us? So this is one of my patients, as a 60-year-old healthy man. He had a total thyroidectomy back in 2007. He did have a node in the carotid bifurcation. It was positive for PTC and extra nodal extension. He had RAI. We completed treatment in 2007, went out for years. Came back to me with a kind of a little bit of a headache and a neck mass around his carotid wall. And I was like, what is this? And I got an MRI, and there was a poorly delineated mass right around his carotid, right? Which was a complete surprise. What did we do? I mean, it's a hard area. You know, you really don't want to operate there. You don't want to know. It's a hard, our radiologists were very reluctant to do a core biopsy because it's right next to the carotid. What did we do? We just did a final aspiration, CT guided. And because we had Thyroseq, we just sent it for that. The tiny FNA confirmed the diagnosis of anaplastic. Not only that, showed that there was no BRAF mutation, but there was an NTRK3. What does that mean? Well, FDA approved one of these new medications that I can never say their name, resected for NTRK. Now, this was back in 2020. I was in the middle of a pandemic. We discussed this case, but everybody was very uncomfortable with just a start an NTRK inhibitor. So this patient went the usual route. We actually consulted with also folks at Memorial. He started with IMRT plus Adriamycin. And guess what? The tumor didn't budge at all. No change. Once we finished that, I said, okay, well, that didn't work. Let's do resected. And the tumor immediately responded and shrunk. Now, when you look back, you say, of course, but just think about it. We just had one FNA that gives us all the information we needed. If you're not excited about that, I think you're a very hard person to impress. Here's another case. There is a 66-year-old man, shows up one day with significant voice change and hoarseness. He had some dysphagia, no swallowing difficulty, no other symptoms. He had a history of hypothyroidism, and then he was a smoker. And goes to ER, ER gets a CT scan, and they see this gigantic thing. Anybody looks at it, man, 66, hypothyroidism. Yep, this definitely looks like anaplastic. Cord is out. We did an FNA. The FNA, they recommended, they felt that this is a high-grade carcinoma of thyroid origin. But they also sent it for Thyroseq. And I was actually preparing this person either for operation or looking at BRAF to see if we can do neoadjuvant. I presented this case at 2 tumor boards. While I was seeing him and I was getting ready for RT and radiation, Thyroseq came back and it showed negative, no thyroid cells. And I really loved the description that says, this is negative for all tested alteration in the sample, at virtually no expression of thyroid differentiated glial cell markers. This may reflect the predominance of non-thyroid cells for the presence of a completely differentiated, although it's less favorable. Because of this, and I'm being very honest here, I said, this doesn't make sense. We can, the anaplastic can fool pathologists, but cannot fool genetics. So I send the patient up. He was in my office. Send him up again. Send him up to our pathologist. They did the biopsy. They said it's really poorly differentiated. And I said, can I please ask you to send for a flow cytometry? And said, this doesn't look like lymphoma. I said, can you please do that? It was sent for flow cytometry, large diffuse B cell. We send the patient for core biopsy. Core biopsy confirmed it. Patient went on to get chemotherapy. And he's alive and he's getting better. So in conclusion, a negative Thyroseq is very reliable to rule out high-risk cancers, and I would argue actually to make you think about other problems like lymphoma. The performance doesn't decline with increasing nodule size. And I would say we are just at the beginning of the dawn of a new age. And you could argue that, maybe Thyroseq might not be very specific, but I would say it's the first step in a giant leap. We are going to do more of this, and we should do more of this, and we should be comfortable with nuance and not knowing, and we should seek data. I'm hoping that one day we can do these kind of genetic testing for all tumors. Look at the salivary glands. They are even more complex than thyroid. Imagine that we have a salivary seq. Hopefully, Yuri, when he's done with the thyroid, can start working on that. That would be huge. Or even for a squim or for everything else. And this is just version 3. I'm sure Yuri is already doing version 5. Imagine how much more we can progress. And do you think in 10 years we're going to even operate on anybody with that genetic analysis? No way. We're going to operate on anybody with T3 tumors. We'll just take them out, take half of their tongue or half of their face out. No way. It's going to change. And it's a good thing. And it's very exciting. That's all I had. Thank you so much for having me. And I love to take a question. And I want to hear what Yuri said.
Dr. Nikiforov, the mic's all yours.
Thank you.
We will wait for the questions to come in, and we will try to answer them towards the end of the presentations. But Dr. Givi, that was just very provocative. I'd love to have a couple of questions myself, but we'll hand the mic to Dr. Nikiforov.
Sure.
Good morning, everyone, and thank you for inviting me to be part of this exciting journal club. And thank you, Dr. Givi, for giving an excellent talk discussing this very informative and interesting paper. These are my disclosures. I hope you all see my slides well, right?
Yeah.
Very good. So as Dr. Givi said, that at the core of today's discussion are these indeterminate thyroid nodules, nodules that by cytology cannot be assigned to either benign or to malignant group. And instead of diagnostic surgery, currently we use several molecular tests to help us to stratify it as likely benign or likely malignant. And making an additional step forward, it's not only negative or positive, but now with a variety of information, and Dr. Givi gave a couple of fascinating examples, we can even more, not only just say that its nodule is likely malignant, but we can say it's likely low risk and likely high risk. And this nuanced approach obviously will help our surgeons to perform the optimal surgery as the first surgical approach. So the whole development of science and development of thyroid molecular testing is based obviously on an extremely extensive understanding of the genetic landscape of thyroid cancer, which has been revolutionized by the new methodology, next generation sequencing. And by now we know really molecular landscape of almost all thyroid cancers. If we look at gene point mutations, gene fusions, copy number alterations, we really can identify most of papillary thyroid carcinomas, most of follicular, Hürter cell, medullary, and so on and so forth. And this wealth of information gives us a tool to apply it to this tiny fine needle aspiration samples. So today, during the next 15 minutes or so, I will try to cover to stress 4 different points. Evaluation of diagnostic test performance, how it's usually performed, factors that affect test specificity and PPV, prediction of cancer phenotype and risk of recurrence using molecular testing, and a few words about the nodule size as the main and most interesting conclusion of the Givi study. So we start with evaluation of diagnostic test performance. We all know that the main characteristics of each diagnostic test are sensitivity, specificity, and PV and PPV. For thyroid cancer, it's also very important metrics as a benign call rate, meaning how many nodules are called benign, because this is something that allows, this would reflect the proportion of patients that we can save, prevent surgery in a relatively safe way. So when we talk about the optimal study design, which study are considered the gold standard in the field? Studies that are prospective, multi-center, blinded, and use consecutive number of samples with surgical outcome. Such studies typically are required to establish the baseline performance of molecular tests. And indeed, Thyroseq and Afirma, 2 main tests, such studies have been published. Why? Because when you do it in a prospective and particularly multi-center manner, this really helps us to minimize the differences between different centers, how patients are managed, how diagnoses are established. So if we talk about Thyroseq version 3, the test that we are discussing, this was a multi-center study, prospective, double-blind, 10 centers with central pathology review, and indeed it showed that test sensitivity was 94% and PV was 97%. Benign call rate was 61%. This is an important metric, which means that about 60% of nodules with indeterminate cytology likely can be spared from unneeded diagnostic surgery. Specificity was 82% and PPV was 66%. This is obviously a baseline. And then, after the study paper was published and the test was released for clinical use, it has been a number of additional, not additional, but independent, typically single institution studies. And those studies, by nature, by default, they have limited surgical outcome, because you would not send all patients with benign nodules for surgery in order to establish true NPV of the test. And this is obviously an intrinsic limitation of the study. So all independent study, when even a proportion of patients was sent for surgery, they still can adequately assess benign call rate, because it just dependent on the test how many samples are returned as negative for molecular testing. Other performance characteristics, sensitivity, specificity, and PPV would depend on 2 factors. They would depend on NIFTP, if it's considered malignant or benign, and would develop on would also depends on what to do with the test negative samples that were not subject to surgery. Do you consider them as a negative? Do you just simply exclude them from the study? And depends on this approach, obviously there will be some nuances, some variability in how the performance of the test is estimated. So this is just the 3 first studies, pretty large studies published from different institutions on Thyroseq after it was version 3 was introduced. Clearly showing that benign call rate varied from 58 to 71%, and in the multi-center prospective study was 61%. So it was reassuring that true that we are approximately in the ballpark, that in various institutions, still with cytology, still we have a close benign call rate. I tried to calculate the benign call rate from Dr. Givi's study, but it was difficult because we didn't know all samples with negative. But I thought it was around 65%. So conceptually, is in the range. And then sensitivity, specificity, and PPV also were much higher than in Dr. Givi's study, but the reason for that we are going to discuss in a second. So first, a few words about NIFTP. NIFTP, I mean, this concept now is well accepted when this is the tumors that are encapsulated and non-invasive, but they already have nuclear features of papillary carcinoma. We believe that they are so-called pre-malignant or carcinoma in situ and reflect this multi-step progression that thyroid tumors, like all other tumors in the human body, goes through. However, it's still important to stress that these tumors require surgical resection to evaluate the capsule to be sure that that invasion has not occurred. So by default, these tumors have to be surgically excised. And for that reason, in most studies, they are counted with the malignant, sort of not benign. Also, again, this is obviously the different approaches how this can be done. So I briefly discussed this large study. This is the largest today study of 415 patients from University of Pennsylvania on Thyroseq version 3 performance. In this study, out of 415 cases, 127 went for surgery. So very similar situations that not all of them went for surgery. And if you, for example, look at this diagram, you see of the negative samples, 294 with Thyroseq, 31 went for surgery, out of which 5 were malignant. So conceptual question here is, when we calculate sensitivity in NPV, do we consider this 5 malignant out of 31 patients with surgery? Or we consider them out of 294 patients, thinking that the rest of the test negative cases are likely to be negative. This is a nuance why I'm stressing, I'm spending time stressing, because that's why the performance of the test would vary depending how you structure the baseline for these patients, when not all of them underwent surgery. And obviously performance in this study was significantly higher. Sensitivity and specificity was in about 90%. Again, because in this, one way to measure test performance was to count the Thyroseq negative cases as negative. But also the authors obviously gave another way of calculating, looking only at the cases with histological follow-up. And the numbers were obviously lower. So again, I want to stress that this is just 2 ways how you can look at the test results when you don't have a complete cohort of patients with all patients that went for surgery. And both ways to approach it are valid, but I think it is just important to keep in mind how this is calculated in any individual studies. Again, if you look at the study by Dr. Givi and colleagues, when we look, I mean, they provide the diagnostic performance as malignant only and malignant and NIFTP. And even here we see that obviously when we count NIFTP with malignant, PPV is significantly higher, from 27 to 61%, because significant proportion, as Dr. Givi mentioned, many patients were follicular variants, probably encapsulated follicular variants. Many patients were low-grade tumors, which were NIFTP, and depending, but then the not philosophical, but clinical questions, should you remove it or not? Yes, after you removed, you feel, okay, maybe you would not need to remove it because it's NIFTP, but truth of the matter is that you probably need to remove them anyway to establish the diagnosis. So that's obviously would have impact how you would what NPV and PPV of your test you will report in such studies. So, but also when we look at the NPV in however way you calculate was relatively high, even not adding the cases with Thyroseq negative and no surgery. And PPV was low. That's what Dr. Givi was saying, that sort of sensitivity, specificity 23 or 36% is lower than in previous studies. So let's for a quick second look at the factors that affect actually specificity and PPV of the test. One of the important factors that affects this performance is the pathological evaluation of thyroid samples, how pathologists read samples with borderline nuclear features of papillary carcinoma. This is one of the many studies in the field, inter-observer and intra-observer variation among expert pathologists in diagnosing thyroid tumors with borderline nuclear features. Basically, there were 6 thyroid experts in this study that looked blindly at 15 cases. So they unanimously agree on diagnosis in 13% of cases, and majority agreement in 40%. About 50%, 47% of cases where experts could not agree if this is a benign or malignant. I think this is something that is very important to understand, that pathology, being a gold standard, still has to, this is not a final kind of cannot be a final metric because, again, of the variability how we do it. So why this is happening? Why expert pathologists gave this different diagnosis? Because in many cases, diagnostic features of papillary carcinoma are clearly absent. In others, they are clearly present for anyone, for a first-year resident. But the problem is that in many cases, they are somewhere in between. They are partially developed. And we need to understand that as tumor develops, it's gradually develop nuclear features of PTC. So, and the pathologists look at this removed sections of the removed thyroid, and depending where the line is drawn, at a very sensitive or very kind of rigid, you will see a different proportion of tumors called PTC or not PTC. This was one of the reasons why NIFTP concept was introduced, to account for these borderline tumors, tumors that are going to become malignant, but not there yet. Still, these tumors, many of them probably needs to be removed. Why we know that there is a progression? Because sometimes we see it in the same nodule. You see it's one nodule with 3 different areas. One area showing completely benign, second area showed partially developed, and the third area showed fully developed nuclear features of PTC. That tells you how the tumor develops through multiple steps. And when we interrupt the development of surgery, by surgery, even if you call it NIFTP, some would call, pathologists call it benign or malignant. This is a tumor. This is a biologically malignant tumor that is developing eventually as a carcinoma. But all of these areas will be positive for RAS mutation, because RAS is an oncogene that gave origin to this tumor. This is beautifully documented in a paper that actually I really like to quote from 2019, where nodules with RAS mutations only, which was detected in FNAs by Thyroseq version 2, but it mentions the same test, underwent surgery at 4 different institutions: Memorial Sloan Kettering Cancer Center, Moffitt Cancer Center, Cedars-Sinai, and Mount Sinai in New York. And if we look at the proportion of RAS-positive nodules that called malignant or NIFTP, it was 83% of them were called 83% were called cancer or NIFTP at Memorial Sloan Kettering Cancer Center, and 15% of them were called cancer or NIFTP at Mount Sinai, in the same city across the road, so to speak. Why is that? Is that because they have different biology? Memorial group can claim that the RAS has extremely high positive predictive value, and Mount Sinai says that extremely negative positive predictive value. No, these are the same tumors. This has happened because the pathologists have different approaches to calling these tumors. This also is very important to understand. So in the studies that we discussed, for us, as you can see, were only 11% of malignant, but there was 40% of NIFTP. So again, if you count malignant only, your PPV will be very low. If you count malignant plus NIFTP, it's already will be approaching 60%. Something that is very important to keep in mind. So next point that I want to make is the prediction of cancer phenotype and risk of recurrence. This is a very exciting new area of molecular pathology. It started from the fundamental TCGA study, which showed us that actually even papillary carcinomas can be split into BRAF-like and RAS-like. And this is they have different pathology and different thyroid differentiation. So why it's important to distinguish them? Because BRAF-like tumors are classic papillary carcinomas or tall cell variant. They have an infiltrative border, and clinically they spread fast to lymph nodes and only later to distant sites. But they're prone to lose markers of thyroid differentiation very early. RAS-like tumors are follicular variant PTC. They are all encapsulated. They have relatively low-grade ultrasound. And they stay encapsulated for a long time. But if they spread to distant sites and almost never to regional lymph nodes. But even at distant sites, they retain markers of thyroid differentiation for a long time. So, and FTCs are also a clear example of RAS-like tumors. So what is even more important is that the molecular markers now can be used to predict risk of recurrence and mortality from tumors. Indeed, tumors that have RAS-like only mutations, they are low risk. BRAF V600E is an intermediate risk, and RAS plus TERT, BRAF plus TERT are high-risk tumors. TERT alone is also getting somewhere in between intermediate and high risk by getting closer to high risk. This was one study from Korea, 500 patients. This is a meta-analysis of 8,000 patients, clearly showing that the presence of BRAF plus TERT, RAS plus TERT, little bit less TERT, associated with extremely high increase in probability of distant metastasis, tumor recurrence, and even tumor-related mortality. So, and now we have this information preoperatively. Looking at Dr. Givi's study again, we will see that there is a group of RAS-like tumors, and this is comfortably tumors that can be treated with lobectomy. There is a group of BRAF-like tumors. This is your BRAF V600E and TRK ALK fusion. This is your intermediate risk cancer. And most importantly, these are the high-risk tumors. TERT plus RAS, P53 plus RAS, BRAF plus TERT, BRAF TERT alone. So, but what is very important, it was only 8% of these high-risk tumors. It means we are not overcalling them. We know that it should be a relatively small proportion, but these tumors that I really need to be treated most aggressively, because these patients have a high chance to recur and eventually die from this tumor. And I want to tell you that there was, in this study, there were 2 cases of TERT plus RAS, which one was NIFTP, one was benign. Don't be fooled by this pathology. These are malignant tumors. These patients need to be treated very aggressively. Otherwise, what happened? This study provides an answer. This is a study from Sweden on TERT-positive adenomas, so-called pathological adenomas. And this is on the bottom one case, which is the tumor adenoma with TERT and RAS mutations, which recurred and eventually killed patients many years later. So pathology is not reliable in these cases because tumor has a biological program to survive at distant sites and eventually give metastatic growth and kill the patient. And finally, I want to finish with something that I found very interesting in Dr. Givi's study, effect of nodule size. So does nodule size alone tell us much about the risk of cancer in indeterminate thyroid nodules? Probably not, really, at least in this study. But in certain other studies, so in certain groups, for example, in tumors with the haploidization type copy number alterations characteristic of Hürther cell carcinomas, every cm of increased size would correlate with increase in cancer probability. And similarly in this study, this has been discussed. I think this is interesting and important for clinicians to start looking at nuances, how the clinical features intersect with molecular findings in order to provide better patient care. So this is my summary. We discussed the assessment of performance of molecular diagnostic test in retrospective studies has to be has some limitations. We discussed factors that affect test specificity and PPV. We discussed role of molecular testing in predicting tumor phenotype and risk of recurrence. And we said that additional clinical parameters will be important to be used in addition to molecular testing to inform most appropriate patient management. Thank you for your attention.
Well, first of all, I want to thank you both for an incredible, very thought-provoking presentations. I think we were all taking it all in. That was a whole lot of information to process, but I myself have a couple of questions to you both. And I want to go back to Dr. Givi's presentation and that initial Alan Ho question. I don't want to be very stubborn about that question about tumors in the bigger range of the size or lesions that are more than 4 centimeters. We saw a limited number of patients that went through Thyroseq and then through surgery, and that's normal. I think that's the nature of the biology of these tumors. But tell us a little bit more of how do we make people believe in this newborn baby? Where do we seek the details? How do you consent a patient that is about to go through a surgery, being a total thyroidectomy or hemithyroidectomy, you name it, whichever the case may be? How do you go through that process, and where do we look for the details to hone in specifically these larger tumors in regards with the results of genetic molecular markers?
Yeah, sure. First of all, I agree with everything that Yuri said. I think we are basically saying the same thing. There's a lot of nuance and there is a lot of differences. I would say the way to do this is to generate more data, to do more tests, to look at our outcomes, to follow the evidence, and to enter this debate with an open mind. We really don't know enough yet. This is just the beginning. We are learning every day, but we should not stop the process of learning. And I would say, as a medical society, understandably, we are very cost conscious. But I would argue, when we started doing H&E slides and when we started doing CT scan, it was pretty expensive too. Now it's routine practice. We have to use this technology more. I am a huge believer in technology and science, and this is how science progresses. We have to fund it. Hopefully we can have this done cheaper, this done faster, and use it more and more so we can learn more and be more confident. As both Yuri and I are saying, there are a lot of nuance, these are ranges. And we all know the human mind hates probability. We just cannot fathom our mind. What is the difference between 30% and 60%? Do I have cancer or not? This is what we want to know. And the way to answer that question is to do more tests, to expand these, and just constantly reassess our findings and look at it, what happened. That's the job of people like me to do aftermarket. Once Yuri and scientists bring a new tool, we have to look at it and we have to interact with them to see how we can use this tool and how this is going to make us better. If this tool is just going to confirm our biases, we are not making progress.
If I may just very quickly to add, in practical purposes, I totally agree with Dr. Givi. I mean, I think that in practical purposes, look at the interpretation of the report, because we put a lot of information into the interpretation. And I honestly can tell you that definitely, even for me, the very large nodules, like with few cells collected from one area, I still remain a little bit by myself uneasy with them. So when they are low risk mutations, this is fine, but they're completely negative, it is probably maybe. So, and I want, as being by myself a molecular pathologist, I can tell you that you still have to rely on clinical judgment. Even if all your tests show that it's negative, but you look at you have all information and it doesn't look sort of, completely benign. I mean, follow your clinical hinge, sort of your clinical feeling for these patients.
And I would argue that's human nature. We all care about our patient. And even when we look at the cold hard science, when we look at the ultrasound and it's a completely uniform nodule, you look at the Thyroseq and if there's no mutation, you still have that nervousness in the back, because at the end of the day, we care. And the only reason to bring down that nervousness, which comes from a good place, not because I want to operate and I want to make money, is because I don't want that person to lose the life, that woman that's in front of us in the office, that mother, that daughter, that spouse, and we are nervous about it. But our nervousness, if it's going against our science, against our finding, will have consequences. Even in best hands, there is a risk of recurrent laryngeal nerve. There is a risk of unnecessary injury. So the more we do, the more we learn, the better ultrasound, better Thyroseq, better thing will supplement our clinical judgment.
Well, thank you so much for your answers. I think, to quote John Salvatier's essay, and I'm really looking forward to read that, let's keep on looking for the details. Thank you for this very thought-provoking presentation. We want to invite you all to come back to next week's tumor board. We're going to have Dr. Int'l moderating an incredible group of very international thyroidologists in a tumor board next week. So that will be our 100th session celebration. So we invite you all to be back here. And thank you, Dr. Givi and Dr. Nikiforov, for an incredible presentation.
Thanks for having me.
Thank you.
Have a great weekend.